This conference will now be recorded.
All right. So today we are going to learn about how to do a structured discussion. Okay, this is a typical query raised by a lot of candidates, and there are many candidates who find it difficult to do structured discussions as compared with your simulated patient tasks. Okay, so today we are going to look at what are the key points to remember while doing structured discussions, and we would be doing a few structured discussions as well. Okay, all right. So these are the things that you need to remember. Okay, one minute, let me, yeah. All right. So coming to each of those points that I have displayed, on to the first one. Okay, so what I would need you to remember in a structured discussion is that um, firstly, you have to read the domains carefully. Typically, in a structured discussion, you would either have three domains that are assessed, or there may be times when four domains are assessed. For example, they may assess if there is no history taking, then only communication with colleague, patient safety, and applied clinical knowledge you would be assessed on. But if there is history taking, then information gathering, communication with colleague, and the other two, that is patient safety and applied clinical knowledge, are also assessed. Now, so that is very important to read the domains, because sometimes they may not ask you the question directly, what further information would you like to take? But it may be important for you to cover this particular domain because it is being marked in the structured discussion, which is why the first point, that is, you have to read the domains well. You need to know what is assessed in the structured discussion. When you open the structured, I mean, when you start your structured discussion, remember to introduce yourself and wait for the questions. Don't assume that this is going to be the question and proceed with the structured discussion. No, you wait for the examiner to ask you questions. All right. Like if it's a labor ward prioritization, gynae ward prioritization, particularly so if the task is not very clear in the 2 minute time that you introduce yourself and you say that I am so and so. I'm one of the candidates for the Part 3 exam and I'm ready for the structured discussion. Okay, and then you can wait, pause, see what the examiner has to say, and then proceed. So it is very important, this particular point. All right. Listen to the question carefully. This is something that most of us, uh, it is most of the candidates may not listen to the question carefully, and hence like for example, if the question says, what is the antenatal management, like in a case of placenta previa, for example, with it's a structured discussion, and what is the antenatal management? There are candidates who would start with antenatal management, then go to intra-op management, then even talk about the post-op management. Remember, this is a structured discussion and they're going to ask you a series of questions. So it's important to stick to the question, because the second question or the third question may be different from what you have already said. And if you answer things out of the question and that is not included in the answer key, that is not being assessed, that is not being marked, then you would simply be wasting time. So that is why it is very, very important for you to listen to the question that is asked. Okay. Then If you have not understood a question, okay, in case you think that you need the examiner to rephrase the question for you, then that's perfectly fine. You can just ask the examiner, could you please rephrase the question for me? And that should be okay. All right. So if you have not understood a question, do not hesitate to ask the examiner to repeat. Okay, and ask in a polite manner to repeat the question. All right. Then, yes, so do not answer what is not asked. Okay, as I mentioned, listen to the question carefully. If it is antenatal management, just talk about antenatal management. If it is intrapartum management, just talk about intrapartum management. And if it is postpartum, only postpartum. All right. If it is a gynae station, gynae theater list is provided to you, and you are supposed to be doing your task just prior to the theater, this is just prior to operating, then please don't go on mentioning about the follow-up, I mean the post-op plan. In case it is only the pre-op, if the question specifies what are the pre-op steps that you're going to take, please don't go and talk about, the post-op early mobilization, enhanced recovery principles in the post-op period. Right now, what is required to be done is to be mentioned. Okay. If particularly so, if the question is very specific, what are the things that you're going to do currently? Okay. Then, yeah. So remember, another important thing is when the question is asked, what further information would you need? Okay, in any particular situation, what further information would you need? It means history, examination, and investigations. All right. So please don't just take the history or just ask history and finish it off. It is important to complete the history, then say that I would like to examine in the presence of a chaperone with consent, and then go on to talking about the investigations. It is very, very important to organize your thoughts when it comes to a structured discussion. Okay. See, when it is a simulated patient task, you are talking to the role player, and it can be a conversation. It would result in a flow of basically you just go with the flow in a simulated patient task. But in a structured discussion, it is very important to organize your thoughts, and it is important to have these subheadings in your mind, at least like history, I'm going to say these points, then examination, these points, investigations, these are the points. So it is very, very important to have an organized structure to your answer. So when the question is asked, what further information, please don't just stop at history taking. It means history, examination, and investigations. And remember the safety point when you mention examination, it is very, very important to say, I would like to examine in the presence of a chaperone with consent. All right. So, yes, so that's about it. Now going to the next. Okay. Yeah, so as I said, have a structure to your answers. Okay. Even history can be organized. Okay. So that you present to see for the examiner, it is easier to mark you if you organize your answer, because they have an answer key with them, which is probably organized. Okay. So even the history itself can be organized. If there is a patient who is pregnant and there is a medical condition or there is some other problem that she's come with, okay, and you are being asked questions by the examiner about her condition, and the examiner asks you what further information. So that history that you say has to be organized into subheadings so that it is easier for you to say things, and it's easier for the examiner to mark you in the answer key. So your history may include the current problems, elaborate on the current problem that she's come with. If it's a medical disease, elaborate on that. Okay. Then if she's pregnant, ask her about the pregnancy, any obstetric complications, booking investigations, how the baby movements have been, any pain, any leaking, blah, blah, blah. Okay. And don't forget the other history that we normally ask in a simulated patient task, like any other medical disease, any surgeries, allergies, blood group, BMI, all those things that we normally ask, those points are also to be covered in a structured discussion. Okay, when the question is asked about history. If the specific question is not asked, what further information? Remember, when management is asked, you would need further information in any case. Particularly so, you need to emphasize on information gathering when the domain is covered, even if the question is not asked. Then, again, so another important thing is, as far as the management is concerned, remember, again, you can divide and organize your answer. Okay? It's important to say in the management part. For example, there is a patient who has come with a medical problem, say patient with say sickle cell disease, and she's pregnant and she's having a particular condition, and the examiner is asking you, say she's having acute chest syndrome. Examiner is asking you some questions about management of the patient. You would all of you would say, I would multidisciplinary team, HDU, blah 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 blah, but nobody would be saying counseling. Okay, counsel the patient, talk to her about her condition, talk to her about what problem she can anticipate. That you would typically forget in a structured discussion, something that you would easily do in a simulated patient task. But here it is important, as important as the rest of the active management that you're doing for the patient. It is as important as that to cover counseling in a structured discussion. So again, the management bit has to be subdivided into headings in your head. Okay, counseling, then management of the condition, and address other factors. Okay, for example, there may be a station where there is a, say, a smoker, a drug addict, a commercial sex worker who's come with some problem, like say for example CA cervix. Okay, so uh, when the management is asked, all of you, typically most candidates, this is what happens. They would address the CA cervix. So these are the steps I would do. These I would do pelvic lymphadenectomy, radical hysterectomy, but nobody would be bothered about her overall condition. Okay, the fact that she's a commercial sex worker, the fact that she's a smoker. Okay, it's very important to address those points as well. Talk about NHS stop smoking services, de-addiction for her, involvement of the social services, then safe sex practices, STI screening. All these things which are related to it is important to manage the patient in a holistic manner rather than just targeting the condition that you are being assessed for. Okay, so look at other things as well. So the management again can be divided in your head into counseling, active management of the patient of the condition, and other factors that you need to address. Okay, all right. So with that, I think we can begin with our structured discussions. All right. So can we have, for the first one, can we have two volunteers, please?
Can I
Yes,
do,
can I
please?
do?
Okay, I want two volunteers. All right, Dr. Humaira and
Sadia.
okay, fine. All right. So the first two questions Dr. Humaira can take, and then Dr. Sadia can proceed.
Okay.
Okay, the first question I'll give to Dr. Humaira. Also remember that time is usually not a factor when it comes to structured discussion. You usually get a lot of time to do a structured discussion. Take your time, even through the station, while you are doing the station, think what you're seeing. Okay, it's easy to finish a structured discussion even in 7 minutes or 8 minutes. All right, so coming to your first station. Okay, you can start. Dr. Umaira. Yeah.
Hello, I'm Humaira, ST5. Yes. Hello, I'm Humaira, ST5 in antenatal clinic. I have read the scenario and I'm ready for the discussion.
Okay, can you
This is
summarize
the
the
case of a
case?
26. All right. So
All
this
right.
is a case of a 26-year-old pregnant Gravida at 36 weeks of pregnancy, and on the background, she had history of renal transplant a year ago, and she's on multi-therapy, polytherapy, taking tacrolimus, prednisolone, nifedipine, azathioprine, cyclosporine, and aspirin, and for the graft rejection medicines, anti-graft rejection medicines. So my further assessment will be by taking her detailed history, detailed examination, and running some investigations and management after the MDT decision.
Okay, so what further information would you like in this case?
So first of all, would like to inquire about her pregnancy. That how so far how is pregnancy going on, and is she having any complaints regarding the pregnancy? Has she named the baby, and how is baby how about the baby's movements, then any problems like any bleeding or pain or leaking. So after that we'll inquire about that whether she had any tests, any ultrasound, and any other investigations done. So regarding her condition of the renal transplant, we'll inquire about the details of the problems, why she had her renal transplant, and it is informed that 1 year ago she had. So would inquire from her about whether she had attended any pre-pregnancy counseling before contemplating this pregnancy, and whether she was given a go green signal for this pregnancy or not. So or whether this is an unplanned pregnancy. Regarding her condition, we inquire why her transplant was done and how is she doing on the medicines. Is she regular? How is the compliance of the medicines and any side effects she is having? When was the last visit to her kidney physician, her renal transplant team? And was there any admission, any graft rejection in the past, or any admissions in the past during this 1 year time? And any further investigations done for her, like her kidney functions? How are the kidney functions done recently? And how about her blood pressure control? And is she taking any antihypertensive medicines as well or not? So after that, we'll inquire about her last periods, and because she's primary gravida, so after that would inquire about any medical conditions like hypertension, diabetes, any risk of DVT or history of DVT, any such problems of diabetes, high blood pressure, and DVT in her family, and whether she's allergic to any medicines or not, any surgeries in the past besides this kidney transplant. So and also inquire about whether she's a smoker or not, and her social habits would be inquired, whether she smokes, takes alcohol, and any recreational drugs, and how is the support at home and her mental health by inquiring her mental health by asking two Woolies questionnaire, and whether she's what occupation she is having, and how is the support at home, and her BMI and blood group and be inquired, and any reservations for blood transfusion, and I will rule out a Jehovah Witness in her. So further assessment will be by a detailed examination. Would examine, would tell her that midwife will check her blood pressure and pulse, and I will examine her by periabdominal examination to see the symphysiofundal height and to see the baby's presentation and the heart cardiac activity of the baby, and also would like to run some investigations which are not available, like would want to know about her recent kidney function tests, renal function tests, and urine for proteins and an infection. Would also like to inquire about her FBC, full blood count, to see if she's having anemia or not. So after that would be guiding her about the management plan.
All right. So this woman had an obstructive nephropathy, secondary to which she had renal failure. A graft was done, and she's on immunosuppressants as mentioned. And these are the additional findings provided to you. Now the consultant wants to consider a cesarean section at 36 weeks. I would like to know your thoughts.
Apparently, looking at her blood tests and all the kidney renal function tests and full blood count, it is apparent that her kidney functions are renal function tests are in a normal range, and she is having anemia. At the moment, her blood pressure is controlled, and GFR is also in a normal range. And by ultrasound, it shows that baby is also growing in a normal range. So as abdominal circumference is in the 10th centile and Doppler is normal, and tacrolimus levels are also normal. So in this case, as there is apparently no reason for cesarean section, so I would discuss with my consultant again whether why her plan for cesarean section is done, because aiming for vaginal delivery can also be contemplated, because apparently there is no reason for her cesarean section. So further discussion with the consultant about the reason for cesarean section will be discussed.
All right. Okay. So, Dr. Sadia, can you unmute yourself?
Yes.
Okay. So, this lady was further taken to 37 weeks of pregnancy, and then her delivery was being planned. So, what are the
Mhm.
precautions that you would take before induction of labor in such a case?
Mhm. Okay, and this is a high-risk pregnancy. Her labor will be monitored in the consultant-led unit, where the multidisciplinary team will be approached, and here we will involve her nephrologist and the renal transplant team. And we make sure that the patient is having the controlled blood pressure, and we do the DVT prophylaxis for this patient. If she's taking any DVT prophylaxis, we will stop it before the induction, according to the dose, if therapeutic or the patient has a prophylactic dose, 12 to 24 hours before. And then we will also see that about the fetal heart, patient will be induced with the prostaglandins. They are safe, and the vaginal delivery is not contraindicated because it's a renal transplant is the retroperitoneal organ. And then we will do the make sure that the patient has the IV line. Meo's chart will be monitored, in which we will monitor her pulse, blood pressure, intake, output record, and we make sure that the continuous fetal heart rate monitoring will be done. And during the labor, the patient will be pain free. The anesthetist will discuss about the pain management with the patient. She can take any type of pain management. During the labor, we will avoid the any nephrotoxic drug, especially in the antibiotic, or the NSAIDs will be avoided postnatally. And then during the labor, we will make sure that the patient has a continuous one-to-one support. Partogram will be maintained, and continuous fetal heart rate will be monitoring. And then we will make sure that the second stage of the labor will be monitored properly, and if the patient has any dehydration will be avoided. And if we have any intervention, especially the episiotomy is given, it will be antibiotic cover will be given. As this patient is having the steroid, which is more than 7.5 milligram from the last 2 weeks, so we will give her the stress dose of the steroid of 50 to 100 milligram, 6 to 8 hourly. To avoid the babies to have the adrenal insufficiency and uh, thymus hypoplasia. And we inform the pediatrician regarding the baby that the mother is taking these medications. He will be need to monitor regarding on the any infection or any these adrenal insufficiency. And the active management of the third stage of the labor will be done. We can give her the oxytocin with the caution, avoid the bolus dose, and we avoid the ergometrin in her case. And after the delivery, we will make sure that patient will be having the intake output record, avoid the fluid overload, and we will also give her avoid the NSAIDs. Any nephrotoxic antibiotic will be avoided. And she can breastfeed her baby, and we make sure that the DVT prophylaxis will given. She will be well hydrated. Active mobility stocking will be mechanical prevention for the DVT will be given, and we start the DVT prophylaxis according to her risk factors. And the RFT will be monitored later on also. She will be in touch with her physician after the delivery.
Okay.
And
What are the precautions you would take before a cesarean section in case it is required?
Cesarean section is only for the obstetric reason. And during the cesarean section, as this is a high risk pregnancy, the graft will be in the overway. Previous surgery can put the high risk of having the adherence. We involve the renal transplant surgeon in her care. Before the cesarean, we make sure that we will do the mapping of the graft by the scan, and it will avoid the injury to the graft. The skin and CN usually give in the midline to avoid the injury to the graft. And the cesarean section, there's a 2% chances of the injury to the graft during the cesarean section. And the uterine NCN will be the transfer uterine NCN. And if there is any adhesion, it will be meticulous adenolysis by the sharp dissection carefully by the experts.
Okay. All right. So that was the last question. Anything you want to add, you can add.
Mm-hmm. Yeah.
Okay. All right. So any reflection, either of you, Dr. Sadia, Dr. Umera?
Yes, Dr. Ankita, I forgot to mention few things like they are very important things as folic acid, I forgot, and also the cervical screening. And in the second question, when you asked that the C-section is planned, so I should have mentioned that there is no contraindication with the renal plant unless there's no fetal growth restriction or the renal function tests are in a normal range. There's no contraindication for vaginal delivery, so it should be contemplated at around 37 to 40 weeks, and in a consultant-led unit with one-to-one monitoring and continuous electronic fetal heart rate monitoring. And C-section will only be opted for any obstetric reasons like fetal growth restriction or preeclampsia.
All right. Okay. Fine. Okay. As far as your first point is concerned, that is about folic acid. Right now, it may not be so important for you to say it because she's now at 36 weeks. Okay. So that's fine. Even the screening, cervical screening that you mentioned, you would be talking to about it in the postnatal part. Okay, so right now, okay, it's okay if you want to know her previous screens, but it at 36 weeks, it's important to just mention the relevant information that would help you in managing her right now. So it is okay if you skip those 2 points. All right. So coming to the first part, that is how will you summarize? And the other thing is that your information. What further information? All right. So first thing I would like to tell you, Dr. Umera, is when you start the station, wait for the examiner. As I mentioned earlier, wait for the examiner to ask the question. Okay. So like you started describing the condition, that's fine, but it is better, it is best for you to wait, and because it will give you some time to process it. You say that I'm ready for the structured discussion, and then the examiner will say, ask you, for example, if he asks you a differential or whatever, it would give you some time to process. So then you can, if see, you can summarize the case if the examiner says summarize. Sometimes there will be so much given in the structured discussion. Now, particularly in the face-to-face exam, there may be a lot of information provided to you. It may not be possible for you to sit there and summarize, and it's possible to summarize, but it would take some time if you just summarize when it is not really required. If the question doesn't involve summarize the case, it's okay if you just start off by answering the examiner's question. Okay, so wait for the examiner to ask question. That's the first thing. Now, if they ask you summarize, yes, you have to summarize and say that this is a lady with it's a case of pregnancy. You can use the S bar. You need not say the situation here is this, background here is this, and I would like to assess assessment. You have to say, but you need not specify. This is the situation. This is the so you can say that here is a lady with 36 weeks of pregnancy with history of renal transplant, and I have the information that the renal transplant was done 1 year ago. She's 36-year old. Sorry, she's 26-year old, and she is on immunosuppressants like these, and she's also on antihypertensives, nifedipine, and aspirin. Okay, so this is how you can summarize. Then you say, I would like to assess further based on history, examination, and investigations, and accordingly make recommendations. So that would be your S bar, okay, for your station. But wait for the examiner to ask question. Okay, that's important. Now, the next question was, what further information would you like to gather? Now, this information that you say is only the relevant information, because the task would, or the examiner would ask you, what is the further information to help you manage this case? So it's just the relevant information at this point, at this stage in pregnancy that you need. Okay, so again, divide your answer, as I mentioned earlier, the condition that we are dealing with. Okay, you did pretty well. Okay, you did divide your history well, but there was a bit of mixing up of investigations you said before. Then you said examination. Okay, and then again you said investigation. So that should not happen. The reason I'm telling you, or reason I'm emphasizing on this, is that even though you say all points, remember the examiner has to sit there and assess many students at a time. Okay, there are many there in a face-to-face exam particularly, there would be students rotating, right? So it is very difficult for him or her to concentrate and mark those points in his answer key if you are not giving him a structured answer. That is why first start with history, then go to examination, emphasize that this is what you're doing, okay? And then go to investigations. You may have to emphasize on certain key points for the examiner to register, okay? So as far as the renal transplant is concerned, elaborate on that. What is the history pertaining to renal transplant that you would need to know? You would need to know why the renal transplant was done. You already know it is done 1 year ago. When was the last visit to specialist? What was decided? What were the medications records, which is already provided to you? Okay, so whatever is not there, you would need to ask. Were there any, as you mentioned, were there any episodes of rejection, etc.? All those things you can mention in the history pertaining to the renal transplant. Then about the pregnancy. Does she right now have any obstetric complications, preterm delivery, any growth restriction, PET, diabetes? Particularly so because she's on tacrolimus, PET because she's having a renal transplant, IUGR again because she's having a renal transplant. Any current complaints that she is having. Okay, you can justify your points here and there. No need of justifying each of those things that you are mentioning in a structured discussion, but here and there, because now she's a case of renal transplant with, she's also on antihypertensives and aspirin. So I would like to know about any history of preeclampsia. I would small for gestational age. So basically, you're trying to portray to the examiner that you have understood the entire scenario. So it's good to justify here and there why you are asking certain points. Then you ask about current complaints, bleeding, leaking, fetal movements, medicines that the patient may be on, in addition to the ones that is already mentioned, that aspirin she's already on. What about her DVT prophylaxis? Is she on DVT prophylaxis? What the tacrolimus levels are? Screening for diabetes is done in pregnancy, etc. Those things. So the pregnancy events. Then you go to the other history. Other history would be medical, other surgeries, allergies, then your smoking, alcohol, drug addiction, addictions, support, depression, but mental health basically, because she's likely to have issues. Then BMI, blood group, reservation for blood transfusion. Smears right now is not really important. It is important for you to counsel her later. Right now, for you to manage the pregnancy, it's not so important. Then go to examination. Examination in the presence of chaperone with consent, check for blood pressure, particularly. Okay, what is important you mention. Do not mention everything. Particular points you mentioned well, actually. Blood pressure, obstetric examination, look for pallor. Then investigations you would like to go through her records for the booking investigations, growth scan for the baby, tacrolimus levels, renal function tests, protein to creatinine ratio, and hemoglobin. These are the important things that you would like to know at this juncture for this patient. Okay, so then the next question was, the next question was, after giving you the investigations, here you said that there is mild anemia. Okay, avoid saying hemoglobin is low. You say mild anemia. That's basically you have to give our use medical terminology. So basically, not just read the investigations, but you have to say what you interpret from the investigations. And as far as you said, renal function is normal. Now, serum creatinine levels, the normal levels would be provided to you in the exam. Here we have not provided, but in the exam, the normal levels would be provided to you. So it is somewhere between 35 to 70 would be a normal serum creat levels in pregnancy. Remember, in pregnancy, there is a dip. In normal pregnancy, there is a dip in serum creatinine, but here it is 92. So there is some increase in creatinine levels. GFR in normal pregnancy is more than 110. Okay. 70 to 90 is stage, if you classify the CKD, stage 1 CKD would be 70 to 90. Sorry, stage 1 CKD would be 90 to 110. This is 73 ml per minute. So normal is more than 110. Okay, so there is mild impairment, you can say, of renal function with a reduced GFR, and there is proteinuria. If you see here, urine protein to creatinine ratio is 310 milligram per millimole. Okay, what is mentioned in the TOG article is if it is more than 300, it is considered a level above which you would consider thromboprophylaxis for her. Sorry, hello?
I thought it is 350. The urine protein is, if it is more than 350, then it is urine proteinuria.
No, 300. You say you consider thromboprophylaxis for her. All right. So yes, so that's the thing. Now the question. This is a question that may be a bit tricky for you to answer because you may not understand what exactly the examiner is trying to ask. So the question was the cesarean is planned at 36 weeks. What are your thoughts? Basically, or what comments? Okay, so basically what you need to say is what you interpret from the situation that is already given to you. What is it that you interpret? What you think may be the cause? Because if examiner or if the consultant has planned a cesarean, he may have had some, he may have put in some thought into it, and that's how he's come to this particular decision. So you need to evaluate why, what are the possibilities that he may have thought of doing the cesarean section at 36 weeks. If you notice, there is mild renal impairment with proteinuria. There is controlled hypertension. Growth of the baby is on the 10th centile, so it's just adequate. Doppler is normal, so baby is okay. Okay. You would like to know if the proteinuria is new onset or not, or if there is deterioration in the renal function. Okay, you do not know her previous values. So when you now have the investigation chart with you, although you're thinking it is mild renal impairment, but has there been a deterioration from her previous renal function? Is the proteinuria new onset now that it is appearing now? So in that case, maybe the examiner is thinking, or the consultant is thinking that she is worsening, and that is why we need to deliver her. Is that so? Okay, so you can have a conversation like this with the examiner, with your examiner. Okay, so I would like to assess. So you need to check if it is de novo or it is arising it is arising now. Okay, so if that is the case, then you would like to assess her further. It could be preeclampsia, biochemical parameters like liver function test, platelet count, any symptoms of severe preeclampsia she could be having, because that is one of the common causes of deterioration at this juncture in pregnancy. Then what was the MDT opinion to begin with? Maybe the MDT has decided or has discussed with the woman for delivery at 36 weeks. So what has been the plan of the MDT? Okay, so it has to be such a discussion with the examiner. So I would like to know what could be the possibilities. Okay, she may be having certain complaints right now, like she may be having some bleeding, fetal movements may be decreased, or there may be leaking, or other obstetric complications may have come up. So you need to ask, you need to discuss that. These may be the conditions why the examiner has considered, or why the consultant has considered delivery at 36 weeks, and why specifically cesarean section. What you said is right, that cesarean section is only for obstetric indications. Okay, so you need to evaluate the entire condition, the entire scenario of the patient, and put across your thoughts. So this is what I'm thinking. Right now, from the picture given to me, this appears as a mild renal impairment. But I would like to know if it has deteriorated from what it was. If the proteinuria is new onset, if there has been new onset hypertension, or there has been preeclampsia features. Okay, what was the MDT opinion? What are the other functions like liver function, platelet count, those things. Any other medical complication that could be coexisting that may need delivery at this time. Okay, I would like to further examine her in the presence of chaperone with consent. And investigations, there is anemia, so I would like to do a peripheral smear, investigate for anemia, ferritin levels, may or may not consider blood transfusion depending on the overall picture, or your iron. Then yeah, so liver function test and platelet count. Then it is important to say that if the assessment shows that she is in a stable condition and can continue, there is no imminent danger to her or the baby, then you could monitor her and take her maybe till 37 weeks. It may not be right to say 37 to 40 weeks, but you say 37 completed weeks, because if you notice, she's already on nifedipine 4 times a day, and her blood pressure is 130/80. There is mild renal impairment. So it is better to consider delivery for you for an ST5. I mean, that the MDT may decide to carry the pregnancy further on. But for an ST5, it would be safer to say that you would consider delivery. Okay, use the word consider at term. Okay, after completing 37 weeks of pregnancy. Okay, and then say that the patient would need to be explained about this. So again, it's important. Counseling is important. Okay, about the delivery and the consequences. All right, clear? Okay, all right. So
Yes, doctor.
yeah. Then going to the next question. The next question was if she's now taken to 37 weeks and then delivery is planned for her. So what are the precautions before delivery? So just say the important points that you would do in this particular case. Okay, you can elaborate about the entire monitoring, but that may be time consuming. Specifically for her, what are the extra things that you would do? You would need to do a CTG before considering induction of labor. Again, the question, if you notice, was what are the precautions before delivery if you're considering induction of labor? So again, need not mention the postnatal management and RFTs and postnatal E, etc. Just mention what is asked. Okay, the reason it is important is because you don't want to be wasting time on saying things that are not there in the answer key at all. Okay, the answer key that the examiner has may include just the answer to this question, which is what are you going to do prior to induction of labor. Okay, so CTG, cervical score, say that oxytocin PGs are safe, which you said. Most of the things you said, Dr. Sadia. Then delivery in an obstetric unit, MDT, thromboprophylaxis, if at all she is on, you need to stop. Confirm blood availability, important. Fluid balance to be looked into. Continuous CTG monitoring because she is having SGA. So continuous CTG monitoring in active labor. Stress dose of prednisolone, now of hydrocortisone. Stress dose of steroid. So you said that it is for the baby. Mind you, it is not for the baby, okay, that you're giving the stress dose of steroid. It is for the mother to withstand the stress of labor. Mother's adrenal hypoplasia would have been a possibility because the mother is on long-term steroid. It is not the babies. Okay, these are the steroids that are used would not be crossing the placenta. Okay, those are the steroids that are used for the mother. The ones that cross the placenta are the ones that we give for fetal lung maturity, or in case we are suspecting CAH in the fetus. That's when we give the steroids that may cross the placenta, not the ones that we are giving here, not prednisolone and IV hydrocortisone. So they are not going to cross the placenta, and they are given, the stress dose is given for the mother, because mother is being exposed to long-term steroids, and that is why there is negative feedback on the ACTH, and which is why the adrenals of the mother may have undergone a little bit of hypoplasia, and the adrenals of the mother may not be in a position to produce more steroids in response to stress. which is why you give a stress dose of steroid. Okay, so it is not for the baby, it is for the mother. So it is the thymic hypoplasia, everything will not come in the picture here. Okay, so that get that concept right. Okay, it is for the mother and not for the baby. Then your third stage of labor, you said you would be basically ergometrin and should be avoided, and active management of third stage to be done. Okay, so then what are the precautions you would take during a cesarean section? Yes, yes, you answered almost everything. Cesarean section, there is a risk of injury to the renal transplant, and it is to be done only in case of obstetric indication. 1 to 2 in 100 would be the chance of injury. So a consultant plus the transplant team should be available. Ultrasound for mapping. Again, here the stress dose of prednisolone would be required. Antibiotics would be required. And you say that yeah, vertical incision may have to be considered, and then your all additional points you mentioned here about adhesions, etc., which is fine. Okay, that's good. Okay, so this was answered well. All right, so overall, both of you did well. What you need to do is make sure that you organize your stations, which is for which you need a lot of practice to get that. Okay, organize your stations. Your stations are organized at this point, like your initial the point of about information gathering was pretty well organized, Dr. Umaira. But make sure that you emphasize on certain things and put it across to the examiners, so in order to catch the examiner's attention to what you're saying, because it is very much possible that the examiner may not grasp what you say. Okay, so hence it is important to organize. All right, so let's go to the next station.
Dr. Ankita, see the first
Yes.
part you say that counseling of the mother for the explanation of the risk is missed here. See,
Hmm. Hmm. Yeah.
so can we accommodate that counseling of the mother with the risk of renal transplant here, or we can left this question?
You should accommodate actually, because yeah, I mentioned it, no, patient to be explained about. So this is about the mode of delivery. Okay, so your this particular point, let me show you. Okay, so patient to be explained about the both the modes of delivery and consequences. That is counseling. You can elaborate on this. Okay,
Okay.
yeah. So you have to elaborate on this. These are just points that we have mentioned here. So you can say that patient has to be explained about her risks, about the risk of preeclampsia, risk to the baby, the risk of growth restriction, and the possibility of stillbirth, etc. And patient has to be explained about the two modes of delivery. Patient can be explained about the injury to the baby, I mean to the transplant in case of a cesarean section, and special team would be required. Those points you can mention, or you can just mention in brief that patient to be counseled and explained about the mode of delivery. Depends on you if you have time or not. You typically you would have time, so you can elaborate. But and even the question here was cesarean is planned, so what are your thoughts? That is why, I mean, it is not the management that is asked. So basically, they have asked you what are the thoughts. So that is why you can just mention briefly what you would do. You would need to, so basically you're trying to say that you're going to take patient's wishes into account, patient's choice into account. So that also is an important aspect while planning the delivery of the patient. So this point here, as it is, you can say in the exam. I mean, it's okay if you don't elaborate too much on it, but the thing is, because the question is not management per se, the question is what are your thoughts now that the cesarean is planned. So you are trying to say that you're going to explain to the patient about the risks and consequences, about the modes of delivery, and take her wishes into account as well. All right?
Oh, thank you so much, Dr. Ankita.
Yeah. Okay.
Dr. Ankita, excuse me, can I share something here?
Yeah, sure.
Yeah, actually, this was my exam question. This one.
Uh-huh.
So yeah,
Okay.
so when this they give this investigation, so examiner
Hmm.
asks me that with this investigation, do you think that what your opinion? You will do the cesarean section? Hmm. So then I
Mm.
told that I would like to discuss with the renal team or also consultant, then
Correct.
take decision with multidisciplinary team, and to
Mm.
see also patient condition, her investigation, patient condition, everything I need to
Mm.
see. So,
Mm. Mm.
but he wants to know that no, it is. I am asking, what is your opinion? You will do cesarean
Ah,
section in this case.
correct. Mm.
With this investigation, you will do the cesarean section. Then I told no. With this investigation, we can wait until
Mm.
37
Mm.
weeks. We can
Mm.
then we can take
Mm.
decision. It is my opinion with this investigation.
Correct.
And
Okay.
patient if it is stable, then he told me, okay, so if you do this induction of labor, so what is your uh, uh, plan, what you can give? Do you think that
Correct. Yes.
prostaglandins and this there is any contraindicated you can give? I don't know.
Mm.
We can induce her prostaglandins, we can give oxytocin. Then
Mm.
after that he asked
The labor
about
management.
that is, yeah, further
Yeah.
management.
Okay. Yes. So that's the same thing. Basically, what I told her to say is that when the question is asked, 36 weeks now, the cesarean is planned. You first start by saying, I would want to know why the cesarean is planned. Okay. And then you
Mm,
say that if it, like how I told you that if there is preeclampsia, if there is worsening of renal condition, because there is mild impairment. Even in the exam, there was mild impairment.
yes,
So, if this mild impairment has always been there, then there is no need for you to do a cesarean or a delivery for that matter, right away. Okay. So,
mm-hmm.
also the patient may be having breech presentation. So that may be the reason why he's planned cesarean section. But at 36 weeks, to plan a cesarean section, unless there has been a deterioration in the renal function or a new problem that has arose, like for example, she's having decreased movements or she's having bleeding. Okay,
Yeah,
so something like that, then agreed. Otherwise, I would like to continue the pregnancy if everything is normal. Like in this case, if you see, I've put, yeah, let me show you the
thank you very
slide.
much.
Yeah, so if you see here, we start by saying what the condition is. There is mild renal impairment with proteinuria, controlled hypertension, growth of the baby is just adequate, Doppler is normal. I would like to know if the proteinuria is new onset or not. And if yes, then other things need to be evaluated. MDT opinion and plan for delivery has to be taken into consideration. Also look at bleeding, fetal movements, what are the problems, any problems that have come up, any medical coexisting problems that are there. If there is nothing, you see, if all of the investigations and assessment do not suggest need for early delivery, patient to be kept under regular surveillance. That's what you need to say. Admit particularly in case of new onset proteinuria here, and review for delivery at 37 completed weeks. Okay, so this is what you would say in the station. Okay,
Yes, thank
all
you very
right.
much.
Okay, so for the next, can we have volunteers?
Me, ma'am, I want to volunteer.
Uh, 1 second. Oh, who was it? I'm sorry, I didn't see the name.
Hafsa.
Hafsa. Okay. And
Shall I, ma'am?
okay,
Thank
okay,
you, ma'am.
Manika. Okay.
Hmm.
All right. First two questions go to Hafsa and then Manika. All right. Let me put the station for you. Yeah.
What he did? Okay, what you do?
There is one more page. So let me know when to shift.
Ma'am, next this.
Yeah.
Okay.
Okay. Hello?
Ma'am.
Ma'am?
Yeah, your time is up. You can start, Dr. Hafsa.
Hello, I'm Hafsa, one of the candidates of the MRCOG Part 3 exam. I'm ready for the discussion.
Okay, so what further information would you wish to know in this patient?
Okay. In the patient is a 30-year-old, in her third pregnancy, dilatation heritage at gestation. Or I missed miscarriage. The ultrasound appears like missed miscarriage. So in this patient, I would want to ask how the conception happened, to know if there was any time she had any ultrasound prior to the last ultrasound that she had, and the results of that scan. I want to know if her menses have been regular prior to that pregnancy. Then now that she's still bleeding per vaginum, I'd want to know the volume of the bleeding, to know if there are any clots or passage of fetal tissue, then to know if there's any fainting spell or dizziness. Then I would also want to know our previous pregnancies, the outcomes of our previous pregnancies, then any medical conditions that she's treating will be inquired about, then to know if there's any fever, then um, any allergies will be asked about, to know if she smokes or takes alcohol or any recreational drugs. Then I want to know the effects of this on her psychological life, and if she's well supported at home. And then we want to know her blood group, and if she has any reservations for blood transfusion. That would be on the history. On examination, I would ask for permission in the presence of a chaperone to check for pulse, blood pressure, temperature will be checked, then abdominal examination will be done for any tenderness in the abdomen. Then the size of the uterus will be noted. Then vaginal examination will be done to check for any cervical excitation tenderness, then any anexial tenderness, any fullness in the pouch of Douglas to be checked for. Then, based on investigations, I'd want to do a urine. I'd want to do a urine pregnancy test, and also there will be a need for quantitative beta ECG. I'd also do a full blood count to check for anemia, and white blood cell count for any infection. Then platelets count will be checked. Then I would repeat the ultrasound to know if there's any retained product of conception. I would also check the adnexia to know if there's nothing suggestive of tuber of ectopic pregnancy in her. And this further review of this patient will depend on the findings.
Okay. So the histopath report has come of the products of conception, and this is the report. What is your differential diagnosis?
Okay. So in this patient with the histopathologic report of nuclear enlargement and in terms of nuclear and supranuclear vacuoles and absence of mitosis or apoptosis and intraglandular papillary epithelial stroma desensitization that are visible, the possibility of the possibility of a molar gestation is possible in this patient. Also, it is possible that there was no gestational sac initially, that the initial what was initially seen in the endometrial cavity could be an Ariastella's reaction to pregnancy elsewhere that is not in the uterus. So it could be a molar pregnancy or endometrial reaction to an
All right.
pregnancy. Okay.
Okay. Okay. Next, can we have Dr. Manik come
Yes,
for the
ma'am.
next two questions? Yeah.
Mm.
Okay. So Agatha had a previous one left ectopic pregnancy treated medically and one spontaneous complete abortion previously. She has no other medical illnesses or any other significant history. She was discharged on the same day as a procedure, that was the DNC, and she came back in 4 days' time to the A&E with these complaints and these findings. Now, how will you manage her?
Four days. Rosie Boiler. Temporary general treatment. Mm. Hemoperitoneum with right ruptured tubal ectopic pregnancy. Ma'am, she should be taken up for with these findings. Already she had a previous ectopic, ma'am. It was treated medically. Now she has come with ruptured ectopic and her pulse is 120. That is, she is having tachycardia and she is drowsy in pallor. So she needs immediate resuscitation and she should be taken up for laparotomy, ma'am.
Okay.
And she has to be,
Anything else?
we have to arrange for blood. She's A negative, ma'am. So compatible blood to be arranged, and she should be asked whether she's having any reservation against transfusion, and she should be explained if she's able to understand. We can, as she's drowsy, she may not be able to understand. Then, in the best interest of the patient, if nobody is available with her, she can be taken up for immediate laparotomy by informing the consultant and under the care of the multidisciplinary team with involving with the simultaneously everything has to happen, ma'am. Resuscitation to be done and the patient to be shifted to OT and operation theatre anesthetist, everybody should be involved, and intensivist will be involved in resuscitation, and the patient will be shifted to operation theater for emergency laparotomy, and the right rupture tube bulb ectopic. So the left tube is already it is damaged, ma'am. Even then, we have to do the needful. If able to, uh, retain the right tube, we can retain, ma'am. She may need blood transfusion, and she needs, as she is A negative, anti-D also to be administered. Blood transfusion may be needed. And before that, we have to go for all the usual routine procedures like WHS, surgical checklist, everything has to be done, ma'am. And she needs blood transfusion. And she needs the IV antibiotics. And you want me to do the post-operative management also, ma'am?
No, the next question is patient underwent a laparotomy and right salpingectomy along with a peritoneal lavage. She received 3 units of PAC cells. She was stable when being shifted to post-operative ward. What measures will you suggest now?
We have to, when the patient is able to talk, when she's able to speak with us, we should go and apologize to what has happened, and we have to debrief her about everything that has happened, and she'll be treated. She'll be asked about her. We will ask about her personal. Uh, how is she? How is she doing now? Is the pain better? Does she need any pain relief like that? That also we have to ask her, and we should go through the mirror shot also, and she should be offered thromboprophylaxis also in relation with the hematologist, and we should verify whether she has been given anti-D and intake out the Mio shot, ma'am. Intake output chart, oxygen saturation, everything is okay or not. That we should verify whether the output is adequate, and incident reporting to be made, and and this should be entered in the e-portfolio also. And if we have to debrief her partner if he has come, we have to debrief our team also, and we have to inform. An incident report should be reaching the risk management team within 24 hours, and the patient should be followed up with the IV antibiotics, analgesics, and as she had the right tube has been removed, she will be having a repeat urine pregnancy test after 21 days, and we should inform her that as she had 2 ectopics, there is a more chances of recurrence of ectopic is there, and if she gets pregnant next time, she should come early to come for early urine pregnancy test and scan to find out if any ectopic occurring. We should find out at diagnose early stage so that we can go for medical treatment, and if she is having any smoking like that habit, you can ask her to curtail that, or NHS stop smoking service can be referral to that can be offered, and if she is having any history of sexually shared infection, or we can do the vulvovaginal swab. If any infection is present, we can treat the same also. What else, ma'am? I do not know. Only this much I am able to see. Then we have to, the consultant also will be coming and communicating with the patient, and she will be under the care of the multidisciplinary team, and the enhanced recovery program will be followed, early mobilization, fluid intake, and everything will be advised, and the risk management team analysis and the the results would be communicated to the patient, and this will be returned back to the GP. Everything will be, and documentation will be done, and she'll be off when she's be getting discharged. She'll be offered a follow-up also, and to come back if any feeling unwell or any pain in the tummy, or if any swelling of the wound, any such things, she should come back immediately. And support groups numbers also will be given, and 24 hours contact number also will be provided to her.
Okay.
Thank you, ma'am.
All right. Okay.
Okay.
Fine.
Thank you.
Okay. So, what are your thoughts?
I don't know, ma'am. In Tamil, they will say, as if you are preparing your sauce and doing so many movements with the spoon like that. I like that feel, ma'am.
Doing so many what? I didn't get you.
Ma'am, do you know Tamil, ma'am?
No. No, I
That's
don't.
why I'm not able to explain. If
Okay,
you
no
prepare
problem.
sauce, you are doing so many movements and getting confused, everything mixed up. That's the meaning, ma'am. Nothing else.
Okay, fine.
Not in
All right.
organized. Thank you, ma'am. Thank you for the
Okay.
opportunity.
Okay. Fine. So, yeah. So coming to your first slide, that is the station. Okay. So here you can see, as I mentioned in the beginning, go through the domains. Information gathering is there, communication is there, and the other three are there. So, what we need to pay attention to is that there is information gathering. So you can expect that as a question. Even if that is not the question, then you would need to score on information gathering by saying the necessary information gathering. Coming to the station says that she's 30-year-old who has come with A&E with abdominal discomfort and bleeding, and it was thought that it was a miscarriage with bleeding. So a DNC was done. Okay, and the ultrasound is attached. So whenever there is a first trimester mishap or there is bleeding in first trimester, always keep these two diagnoses at the back of your mind: ectopic pregnancy and molar pregnancy, in addition to miscarriage, of course, I mean abortion. Okay, so these two problems that can happen in the first trimester, you need to keep at the back of your mind. And then as you go through the station, you can rule out those. Okay, I'm going to just mute somebody is unmuted. Mute. Okay, fine. All right, so then going to the first question, what further information I would need? So this, let's come to the ultrasound picture before that. So the ultrasound here is showing some structure in the uterus. This is the uterus, and there is some structure there. Now it
Ma'am,
is not very, yeah, hello?
shall I interrupt, ma'am? Is it a
Yeah,
pseudosec, ma'am? Thank you, ma'am.
yes. It would be a pseudosec here that you find out later when you do the station. But at this point, when the ultrasound is just provided to you, you do not know whether it is a missed miscarriage, where the gestational sac may not have its regular contour that it otherwise has. So it can still be a miscarriage at this juncture. You do not know. So you want to evaluate further. It can be a pseudosac. You have to evaluate the adnexa, as Dr. Hafsa rightly said. Okay. So then the next question, what further information? Let me go to the question answers. Okay. So when what further information in this case is asked, yes, you have to start by elaborating on the current complaints, how the current complaint started. And it can be ectopic. So ask about any fainting episode, any shoulder tip pain, what amount of bleeding, then any bowel bladder disturbances, all those things that we usually ask for ectopic pregnancies. Okay. Then since it's given to you that it's the third pregnancy, ask what has happened in the previous pregnancy. So obstetric history, in the previous pregnancies would be important to ask. And what about her menstrual cycles? So to know exactly where she is in her pregnancy, whether she's had irregular periods or regular periods, because then it will tell you about the reliability of that 6 weeks pregnancy duration. Then whether this is planned, unplanned, spontaneous conception or aided conception, because again, that would increase the risk of your ectopic pregnancy. Then a contraceptive history as well. Then medical, surgical comorbidities, which is standard. Other history. Go to the other history after that. Medical, surgical comorbidities. SAD, SAD as is basically a mnemonic that we used to use. So it is smoking, alcohol, drug addictions. ASS is basically allergies, support, sexual history. Yeah, like here, what is important is history of sexually transmitted infections, because she could be an ectopic pregnancy. And BBB is very important here. Blood group is very important. I'm not quite sure if you said blood group. Your voice was actually breaking, Dr. Hafsa. But if you haven't, then it's very important in any, particularly in any pregnancy mishap. Okay. I'm not sure. I'm not getting you. The voice is not very clear. That's why I couldn't hear. Anyway, fine. If you have said, then fine. Okay, then what are the blood? I can't hear you. Hello?
Hello?
Yeah, yeah. Now I can hear you better.
I asked about the outcome of previous pregnancies and our
No, no.
cycle.
I'm saying blood group. Blood group.
Yes, I
Blood
asked.
group. I'm. Okay, okay. I couldn't hear your station because there was a lot of disturbance. So, okay. So, blood group is important. Okay, then blood investigations, beta HCG, you said. Okay, so beta HCG is important here because you are kind of suspecting possibility of an ectopic pregnancy and hemoglobin. Okay, you need not say all the TC, DC, which is not really required at this point of time. Okay, ASS is a short form. We were using this particular mnemonic. Somebody is asking about ASS. So we were using this mnemonic to remember history, in history, SADS and triple B. SADS is smoking, alcohol, drug addiction, allergies, sexual history, support, and smear history. Here, what is important is sexual history and support, not smears. Okay, so that is a mnemonic that we would use when we were studying for the Part 3 exam. BBB is blood group, BMI, and reservation for blood transfusion. Okay, so that is why we even tell our students in the course about this mnemonic, because it helps us remember these things when we do the history taking. Okay, so blood investigations other than that would be hemoglobin and beta HCG counts, and platelet count is not really required at this point unless you're thinking of, say, sepsis and other things. Okay, so that is not really required here. Okay, sorry. Now, when the picture was given to you, this is the picture. Okay, so and here it is mentioned that the endometrial lining shows nuclear enlargement, which can be a pregnancy event. Normal nuclei to cytoplasmic ratio, which is normal, intense subnuclear and supranuclear vacuoles, and absence of mitosis, apoptosis, along with intraglandular papillary epithelial tufts, stromal decidualization, which is a feature of pregnancy. That means there is pregnancy somewhere, but there is no chorionic villi seen. So what do you conclude from this?
That there's no pregnancy in the uterus.
Yes, correct. So it can be a Arya Stella reaction, as you rightly said. Okay, good. Yes, it could be an Arya Stella reaction. One thing. It cannot be a molar pregnancy. It cannot be a complete molar pregnancy. Okay, as somebody messaged, and I think you said molar as one of the differential. It cannot be because there is no trophoblastic tissue found. Okay, so that rules out your molar pregnancy. Okay, so it can be either an ectopic pregnancy with Arya Stella reaction, or it may have been a complete abortion, miscarriage that has already been complete. okay, and there's nothing left in the uterus. By the time you did the DNC, the abortion was complete. That may be a possibility, but important DD that you have to consider is ectopic pregnancy with ARIA-Stella reaction, not molar pregnancy. Okay, make it very clear that when there is no trophoblastic tissue, it cannot be a molar pregnancy. It cannot be an intrauterine pregnancy at all. So no molar pregnancy. Okay, so it can be ARIA-Stella reaction with ectopic pregnancy and or spontaneous miscarriage. Okay, clear, Dr. Hafsa? Hello. Hello.
Clear,
Okay,
clear,
never
ma'am.
mind.
Yeah, it's clear.
Yeah, okay. Okay.
Clear, it's clear.
Yeah. Okay, fine. Then the next question was, the picture was provided to you, Dr. Manikam. Next question, that she had a ruptured ectopic pregnancy and there was hemoperitoneum and she was in shock. Okay, she had, let me go to the chart. Okay, BP was maintained, but there is tachycardia and there is a patient is drowsy. So likely that she is kind of going in shock and there is significant hemoperitoneum. Okay, so this is an obstetric emergency. Okay, that's how you start. Okay,
Okay, ma'am.
so hemodynamic instability with ruptured ectopic pregnancy with hemoperitoneum. You said it needs emergency laparotomy. Now, don't forget what we had discussed in the last class. Okay, you said all of that. You said, I mean, the way you said was right, but like resuscitation first and then laparotomy. But who is going to say the points in resuscitation? Those are also counted in the exam. Remember that. Okay, so you say, I would start the steps of, this is again a hemorrhage, right? So steps of resuscitation, communication, our first class that we had together. So resuscitation, communication, investigations and monitoring, and the definitive treatment, that is arrest of bleeding, would start simultaneously. Four components of managing an obstetric emergency. Okay. Communication would be inform consultant first thing, because if you don't say these points, you are not going to score. And I was waiting for blood transfusion till the end because you said it at the end. If you had not said it, you would get a 0 on patient safety. It's like that.
Okay,
Because
ma'am.
this is a very important point. Okay, blood transfusion. Okay. So if you are organized, that is why organizing is important. If you organize your answer in this manner, you will remember. Okay. So you
Yes,
say
ma'am.
communication. Whenever there is an obstetric emergency, remember me telling you these 4 components. Okay. Because I've had a lot of candidates telling me this, that every time there's an obstetric emergency, we remember you saying communication, resuscitation, investigations, and arrest of bleeding. So you can do that. Okay. Try to remember me whenever there is an obstetric emergency.
Yes, ma'am. Yes,
So
ma'am.
say communication, so resuscitation, investigations, and treatment. All right.
Yes,
So
ma'am.
start by
Yes,
saying, I would inform the consultant, the nurse, the hematologist, anesthetist, porter, and scriber. Okay.
Okay.
Just like how we do in PPH, because it is the same thing. It requires, patient is drowsy, patient is in a bad shape. So patient requires resuscitation. So consultant, nurse, hematologist, anesthetist, porter, scriber. Okay. Delegate task. Then in resuscitation, airway, breathing, circulation. Lay the patient flat. Pass 2 wide bore IV cannulae. Start crystalloids, 2 liters first. Okay. Till blood arrives. Once blood arrives, PEC cells to be started. Okay. And blood components accordingly. Then investigations would be everything. Complete blood count, renal function test, INR, blood group, and cross match. Okay. Cross match you should say. Pass a Foley's catheter, delegate task for the same. All right. Then you say definitive treatment would be consent, WHO checklist. Whenever shifting to theater, don't forget consent. Again, a safety point. Okay. Consent, WHO checklist, laparotomy, and right salpingectomy. Explore other pelvic organs, note the other side tube as well, because as you mentioned, the other side tube may be unhealthy. But remember, if it's a ruptured, then it is very unlikely that you could save the tube, which is ruptured. Okay. So it is quite likely that you would need to proceed with a salpingectomy. So it's okay if you say salpingectomy and a peritoneal lavage. All right. So That's important. And then, yeah, so then the next question. So, okay, so this is, okay, somebody is asking what is delegating task. You cannot be doing everything yourself, right? So you have to say that I would delegate the task. That means you would ask somebody to help you. That is why mentioning communication is first is important. Okay, so delegate task is to allot task to people that of your team. Okay, ask your registrar, your junior registrar to pass the Foley's catheter. Ask the nurse to collect blood. That is called delegating task. That's important to do. Okay, so you have to work as a team. You alone cannot do all those things, right? So consent, WHO checklist, laparotomy, antibiotics also you can make a mention of over here after checking allergies and shift to theater. As far as the post-op management, yes, you did a very good job. You gave a very elaborate explanation of your post-op management. You can mention points. So you would monitor on Meow's chart in an HDU there or an ICU, depending on her condition. Analgesics, antibiotics after checking allergy. Thromboprophylaxis may be required, but after tiding over the immediate crisis, like if she is if she's having coagulopathy, then you would, after correcting that, you would say early
Yes, ma'am.
mobilization, enhance recovery principles. You can say out catheters may be out, etc. All those things early, enhance recovery principles to be followed, and NTD prophylaxis to be needed because it was given that the blood group is negative. Counsel about future pregnancy and the follow up early. You also made a mention about red flags, and that is fine. If you say it's not wrong, I've just mentioned the specific things over here. So, but don't say that you would ask her to come back in case of fever. You just say that I would talk. At discharge, I would explain to her about red flags, about contraception, and about the coming back in the earliest in the next pregnancy, and the D's. Don't forget the D's. So you said, okay, DETICS, that is incident reporting, debrief, duty of candor, and maybe a reflective practice would have to be done in this because it was kind of missed, right? So this ectopic pregnancy was missed. So you have to do a reflective practice, a feedback session. Okay, all those things you can say in this particular situation here. Okay. All right. Somebody is asking about delegating tasks to you cannot be possibly saying who you're going to delegate the task to, because it's not like you have a team that is, I mean, the team members are not given to you. It's not given to you. You have the ST2 with you. You have midwife with you, or you have nurse with you. It's not given. You just say that you would go be delegating tasks. You have already said what are the components of communication, or who you would like to communicate with. Okay, so your porter, scriber, anesthetist, hematologist, nurse, inform consultant, you will have your team of your registrars with you, so they are all there with you. So here you need not, it's not a task that is assessing whether you're delegating the task as per competence. So it is just a, it's basically what are the steps that you would take. It is enough if you say I would communicate, resuscitate, investigate, and delegate tasks to the team. You need not say ST2, ST3. It's not needed over here. Okay. It depends on who you have with, I mean, who you are with in that particular situation. Okay.
Okay.
Yeah. Okay. That was a question in the chat. So anyway, fine. So yes, so that was about it. Okay. So first trimester complications, remember ectopic molar pregnancy can be the differential, but if there is nothing found in the uterus, it cannot be an intrauterine pregnancy. It would be an ectopic pregnancy or a complete miscarriage. Okay, fine. So let's go to the last one. Two more volunteers.
Can I do?
Can I, Dr. Ankita?
Can I?
Dr. Salma and Dr. Shanoy?
Yeah. Yes, ma'am.
Dhanya Shanoy. Okay. Yeah. Okay. 1 minute. Yeah.
Yes. Next, please. Hello.
Hello? Yeah.
Next.
No, there's one page, one slide. Okay, you can start.
Hello, I'm Dr. Salma, one of the candidates today. I'm ready to answer your question.
Okay, so can you give me your differential diagnosis in this case?
Yeah, this is a 28 weeks, and she came with the pain on her tummy towards the left line. So first of all, I diagnose as a that she it could be urinary tract infection. It could be that any like hydronephrosis or any problem with kidney, and it could be that preterm labor. Yes. Next, please.
Okay. What further information would you need in this case?
Yeah, further information. First of all, I'll ask her about the pain. That is it her first time that she has this pain, or before pregnancy she has pain, and is it spread to somewhere else or only in left loin? She has any burning micturition and any blood in her urine, and she has taken any medication for that. She has treated before with urinary tract infection, and she has any pain also like sign symptoms of preterm labor. She feel any uterine contraction, and how is her baby movement? Any thing that bleeding or abnormal discharge or leakage down below, I'll ask her. Then I'll take her medical history that she has any infection like sexually transmitted infection with signpost, and also I'll take her history that she has any surgery before, any she's smoking alcohol or recreational drug, she's taking any medication now, any allergy to any medication, and then how is her support at home and her BMI and what she's doing for her living. Then I'll, with her consent and in front of chaperone, I'll examine her that to see the pain and also that the growth of the baby and the fetal heart. Then I'll offer her investigation that full blood count to see that there is any infection, and urine analysis to see there is a urine infection. If it is, then MSU also I'll offer her. And then I'll check her. I'll tell the midwife also to see that blood pressure, pulse, and any temperature to exclude there is any infection, and urine dipstick also. Then I'll check with scan there is any problem with kidney or baby is fine, any growth abnormality, and I'll review her file also to see that before there is any problem with her ultrasonography or any infection. Then I'll check her perispicular examination. There is any abnormal discharge, I may take swab. Next, please.
Okay. So now she was found to be in preterm labor, and uterus is contracting at 2 contractions in 10 minutes, and cervix is 2 centimeter dilated. What's your management plan?
Yeah. So this patient, first of all, I'll explain her with sympathetic and empathetic way her diagnosis, and then uh, I'll offer her admission, and she'll be seen with multidisciplinary team. That means my consultant and the pediatrician, neonatologist, and specialist nurse, midwife. So all will be in her care. Then after admission, we'll give her the pain relief after checking her the allergy, and we'll give her that steroid injection to lung maturity for the baby. And to cover the steroid, we'll give her tocolysis. That means dexamethasone, 12 milligram, 24 hours interval, 2 doses. Then when the delivery imminent, we'll give her magnesium sulfate. After that, she should be seen by the nurse, the midwife, specialist midwife, that pulse, blood pressure, temperature, and her to see her contraction and continuous fetal monitoring to see that how much she's progressing. And then we'll contact with the neonatologist that cord is available or not. If not available, we may transfer her another hospital, and will contact with the neonatologist and gynecologist that the cord is available other hospital or not. After that, we'll check her that she her vital sign and progress of labor, or if she's stable, then uh, she should be seen by consultant also. If everything is fine, then we'll continue her pregnancy up to 37 weeks. But if
Okay,
she's
all right.
progressed, if she progressed,
Okay, the next
then
question
we'll
to Dr.
deliver her.
Danya.
Yes, ma'am.
Okay.
Thank you.
Can you tell me if now it is known that there is no cot in the NICU available, how are you going to counsel and what are the steps that you're going to take?
Uh, so now my patient, she's in preterm labor, and there's no cot in the NICU. So first of all, I would communicate with my consultant, the neonatologist, as well as the labor ward director regarding this, and confirm that. And if there is no cot available, then I would talk to her in a sympathetic and empathetic manner the need for an intrauterine transfer for the benefit of her baby. That is, the baby is preterm, the baby is only 28 weeks, and the baby might require respiratory support and the need of an NICU. So, the NICU cot is not available. So, we would like to transfer you to a better facility, a level 3 care with a good neonatologist, and where labor cot as well as an NICU facility is available for better care of you as well as your baby. That would be communicated to her. And meanwhile, I would continue the tocolysis until the intrauterine transfer is made, and I would inform her that the transfer would be made in an ambulance with a nurse available, with a doctor on call available, with a doctor available inside, and her partner also, if wishes to be available inside the ambulance, and that all the resuscitative measures and the delivery measures would be available inside the ambulance, and the ambulance would have magnesium sulfate, this thing, and calcium gluconate and delivery set, as well as a neonatal resuscitation set available. And the nurse as well as the doctor who's inside the ambulance would be well known about the how to conduct a delivery, as well as how to do the initial neonatal resuscitation if at all required. Then I would tell her that not only steroids, if she goes into preterm labor where the delivery is going to be imminent, she would also be given injection magnesium sulfate for the neuroprotection of her baby. And meanwhile, she'll be monitored for her respiratory output, urine output, respiratory rate, urine output, knee jerk, and all that. And I would make the
Okay,
arrangements
so
for
you
an
have
intrauterine
arranged for
transfer.
a cot in a nearby hospital, and what would your immediate action be before shifting the patient to the hospital?
Before shifting
Just
the
before
patient to the
shifting the patient.
hospital, I would personally call and ask that particular unit where the labor cot is available or not, and whether the neonatal facility is available. And I would also inform the consultant obstetrician as well as the neonatologist over there regarding the transfer. And I would also prepare a reference note for her. Incorporating her history, the management that we have given to her regarding the tocolysis, whether steroid cover has been given, whether magnesium sulfate cover has been given, and a brief summary of her case, whether she had any other risk factors as well, and would provide for the transfer.
Okay, so now she is 4 centimeter dilated and getting good contractions. What are you going to do right now?
Now, as she is in active labor, I would discuss with her regarding the need for magnesium sulfate and for neuroprotection of the baby. So I would give her a loading dose of magnesium sulfate, 4 gram IV, and also continuous infusion of 1 gram per hour. Meanwhile, I'll be checking her respiratory rate, urine output, knee jerk as well. And if at all any of these parameters are deranged, then I would send for a serum magnesium level. And I would make all the necessary precautions, inform the neonatologist, and monitor her vitals, monitor her baby's heartbeat, and when she delivers, proper care would be given, and postnatal early early breastfeeding, mobilization, and venous thromboprophylaxis would be given to her, and also emotional support would be given to her. She'd be properly counseled. That's all.
Okay, fine. Time is up actually. Okay, yeah. All right. So, any reflection?
Didn't feel it to be organized. I was blabbering some things here and there.
Okay, okay, fine. All right. Okay, let's go through the station. All right. So yes, so she is 28 weeks in her first pregnancy, and she's having some tummy ache. Okay, so here your differential was the first question that was asked to Dr. Salma. So in differential, again, it's important to organize. Okay, differentials could be related to the pregnancy or non-obstetric causes. Okay, like you mentioned UTI. I know because it's loin pain, you mentioned UTI first, pyelonephritis, but it could be either pregnancy related or not non-pregnancy or non-obstetric causes. Okay, so pregnancy related would be, or if you're thinking of UTI as the first differential, then you start with your non-obstetric. That is fine because it's given as loin pain. It is not described as preterm labor. So non-obstetric would be UTI, pyelonephritis, renal calculi, musculoskeletal trauma, colitis, gastroenteritis. Remember the other organs that are there. Okay, neurological, head neck cell torsion. Okay, so these are the other differentials that you would give in this particular station. The obstetric problems would be preterm labor, abruption, In case of a fibroid with pregnancy, red degeneration. Okay. Then chorioamnionitis, don't forget this. Round ligament spasm. Okay, round ligament spasm, I agree, would be typically in the lower abdomen, in the it won't be in the loin, but a differential of the pain can be one of the rare differentials. Okay, so and these are your differential diagnosis, and this is how you would organize. Okay, okay, Dr. Salma.
Yes, actually, it is loin pain mentioned, so that's why I didn't go
Yeah,
through
yeah,
details. Thank you.
correct. I agree, but the preterm and abruption, these things have to be kept in mind whenever there is pain in um, pregnancy, advanced pregnancy.
Mm.
Okay, then what further information? Again, divide your answer. Divide your answer based on the complaint. Okay, the complaint was pain. So elaborate. Pain, you would need to know the character, whether it is episodic, because that would go in favor of preterm labor. Whether what is the site, exact site, whether there is radiation. Radiation would be neurological pain. Then or onset duration progress, whether the pain is coming more frequently now, again in favor of preterm labor. Okay, so first the complaint. Okay, so this is how you would divide your answer information. Complaint first, then rule out the other differentials. Okay, you have a differential diagnosis in mind. You said UTI, so you don't want to ask about fever, gastrointestinal problems, nausea, vomiting, diarrhea, urinary infections, so burning micturition frequency, hematuria, history of trauma, any spinal cord symptoms. Okay, so this is for your differential. So first part is about the pain, second part is about the differentials. Then, since preterm labor is one of the differentials, ask specifically whether she's had history of repeated UTI, any cervical trauma, cervix surgeries, leaking, bleeding, how are the baby movements, obstetric complications. So in the pregnancy part is covered here. Then go to the rest of the history. In the rest of the history, certain important points are there, like abuse. Okay, domestic violence could be one important cause of pain during pregnancy. Medical, surgery, smoking, alcohol, drugs, all that, abuse, mental health, again important, okay? Because it could be just a psychological thing. Allergies, blood group, BMI, those are the other history which is important. Then examination in the presence of chaperone with consent, okay? Always remember examination in the presence of chaperone with consent. You say you would check her observations, blood pressure, important. You're considering abruption as a differential. So blood pressure, pulse, for abdominal examination, obstetric examination, see if there are any contractions, look for loin tenderness, per speculum examination. Okay, if you're suspecting preterm labor. Now she's 28 weeks, so you need not be talking about ultrasound for cervical length. You can say ultrasound for checking for looking for any stones, renal stones, like, that is fine. Or the baby's weight, that is okay. Baby's weight, baby's presentation, that's fine. But as far as the guidelines is concerned, that is the NICE guidelines would say that less than 30 weeks, you would take it for granted that it is preterm labor if she's having contractions and there is, if she is threatened preterm labor, basically. But more than 30 weeks, you need to, in order to diagnose preterm labor, you need to offer an ultrasound to look for the cervical length. Okay, so that is what is,
Excuse me,
uh,
nice guidance.
yeah.
Sorry, can I interrupt here?
Mm-hmm.
Yeah, first of all, that ultrasonography, yes, I told that if there is any kidney problem to
Mm-hmm.
see,
Yeah,
and also
yeah,
baby growth
correct.
also. Okay, and
Yeah, yeah.
that according to the NICE guideline, the cervical length, it should be if equal or more than. That means if you will see that with the transvaginal ultrasonography, it should be equal or more
Hmm.
than 30 weeks.
Yeah, yeah, that's what I'm saying. So here it is
It,
not required.
yeah, here it is not required.
I'm just
Thank you.
saying that it is, in this case, it is not required. It is
Mhm.
required if she is more than equal to 30 weeks. Okay, here you
Th-
can take it for granted that she is in preterm labor.
Yeah.
Okay. Also, in
Correct.
addition, you would send midstream urine for culture. Okay, and CTG for the baby initially at least. Okay, may
Yeah.
not be very specific CTG in preterm, but at least initially you would a normal CTG would be reassuring for you. Okay,
Yeah.
so that's about the information gathering. Okay, so organize your answer in this manner so that you don't forget points. Okay, domestic violence is important in the station. That would also be one of the differentials. Okay. Now coming to management of preterm labor. Now, as I mentioned earlier when we started the session, management is not just what you're going to do for the patient. Management, it also involves talking to the patient. Okay, so counseling her, that is very important in this station because it is preterm labor. If she delivers a preterm baby, what are the consequences? Okay, what are the risks to the baby? All of that has to be said. Okay, so divide your answer on management into counseling and the active management for the patient. Okay, so your counseling would be information about consequences like risks of RDS, NEC, IVH, low birth weight, okay, and its consequences, jaundice, long-term morbidity, survival in your unit, okay. Have the neonatologist talk to her about the baby. So it would be your consultant, you would need to inform your neonatologist as well and confirm if there is an ICU bed. That's the first thing, actually. And if there is, then also if she's comfortable, she can be offered a tour of the neonatal unit. Okay. Then steroids, tocolysis. Okay. When you mention steroids and tocolysis, you also need to mention the doses in the structured discussion. Okay. So you mentioned doses, betamethasone 12 milligram, 2 doses, 24 hours apart, and tocolysis nifedipine 20 milligram initially, followed by 10 to 20 milligram, 3 to 4 times a day. So that would be nifedipine is preferred or atosiban. Okay. Then your magnesium sulfate, when you say if she's in advanced labor, then you offer magnesium sulfate. Okay. So again, the dose would be IV 4 gram over 15 minutes, then 1 gram per hour for 24 hours or until birth, whichever is earlier. Okay. Monitor on CTG. Discuss the modes of delivery as well. Okay. The baby may be in breech, baby may be transverse. You do not know. So again, there may be obstetric indications for a cesarean section. So you need to discuss with her the mode of delivery. Discuss with her the fact that cesarean section at preterm gestation may be difficult. Okay, and sometimes may be needing a vertical incision, etc. So because of the poorly formed lower uterine segment, which is in this case unlikely because she's in preterm labor. Okay. Then GBS prophylaxis if advanced labor and support documentation. These are important aspects as well. Okay. Next, if there is no cot, what do you do? Okay, for there is no cot, then you need to inform your consultant, inform the neonatologist, then you inform the labor coordinator, as Dr. Shanoy rightly said. Then you would need to make a few calls depending on what mode you use. There is something called as emergency bed service, which is a central number that you call, and they would coordinate between hospitals and find out which is the nearest hospital that has a cot available. Okay, for the mother as well as the baby. That's important to say. Okay, you would transfer her to the hospital that has a cot for the mother as well as the baby. Okay, then you discuss with the uh, hospital staff that you would be referring to, the neonatologist as well as the consultant obstetrician, preferably, or the registrar. Okay, preferably the consultant, and document, have somebody known to her to go with her. The midwife would accompany her. And when I asked you what are the initial steps, that is, okay, wait, I think I have not, all right, I think I've not included that slide. Okay, never mind, I'll just explain to you. So what are the initial steps that you would take, or what is the immediate step before shifting? That the answer to that is you would do a per vaginal examination to confirm whether she's in advanced labor or because preterm labor you cannot really predict. The labor may arrest, the process may arrest, or she may just go in advanced labor, just like that.
Okay.
Okay, so you have to repeat upper vaginal examination just before shifting her. Okay, regarding
Okay.
magnesium sulfate, it may not be right to shift her on magnesium sulfate. First of all, magnesium sulfate is given while when in advanced labor. Okay, when in established labor, you wouldn't give magnesium sulfate earlier, like she's 1 finger dilated or 2 centimeter dilated. You would not give magnesium sulfate. So when you are shifting, okay, you're not shifting her in advanced labor, you're shifting her in early labor. So the question of magnesium sulfate wouldn't arise. But if at all you have started magnesium sulfate for some reason, you have to say that you would stop magnesium sulfate while she's being transferred. You cannot shift her with magnesium sulfate on. Okay, it's an infusion
Okay.
because it can suddenly uh, go in. So you have to shift her by stopping the magnesium sulfate. The only thing that you're going to give her is tocolysis. All right. And about delivery in the ambulance and all that, that is fine. That is in any case. Okay. But what the immediate step prior to shifting is do upper vaginal examination to confirm if she is in early labor or advanced labor. Now, when I say that she is in advanced labor, 4 centimeter dilated, what are your steps? You would say that you would need to talk to her, you would need to deliver her, to ask her in need to deliver as in you would let her deliver and talk to her about the consequences of the baby if you have not already mentioned those for the baby, and that you would need to transfer the baby ex utero. Okay, so when she's in advanced labor, it may not be safe. What I'm trying to assess is patient safety. It may not be safe for you to transfer the patient when she's in preterm labor and in advanced labor. Okay, so then in that case, you deliver the baby and you transfer the baby ex utero along with the mother. Okay, so the steps that, and you say that then if she's in advanced labor, you will stop tocolysis. Okay, so
Okay.
there's no point continuing the tocolysis when she's in advanced labor. You would stop tocolysis and shift her after delivery ex utero.
Okay.
All right.
Yes.
Okay, any questions? Okay,
No, thank you very much.
fine. So the take-home message from today's class would be when it comes to structured discussion, organize your answers. Okay, like for example, in this case, management would be divided into counseling and active management. Okay, then your history taking, information gathering about the complaint that she has, about the differentials, ruling out differentials, risk factors, other history, examination, investigations. All right. Okay, so that is what you need to do in your structured discussions, particularly so because you want the examiner to grasp the things that you are saying. Okay, because it is very difficult to concentrate when he or she is testing so many of you, particularly in the face-to-face exam. Okay. All right. So that was the last
Yeah, thank you.
station. Okay. Good night. Happy study.
Thanks. Thank you. Thank you. Good night.
Thank you so much, Dr. Ankita. Thank you.